A very good evening to one and all. I am Arpita from the IGCP group. On behalf of IGCP, it's pleasure to welcome each one of you to this webinar on pearls in the management of posterior circulation stroke, held in recognition of World Stroke Day. Today, we are honored of hosting Dr. Lieutenant General C.S. Narayanan Sir, an eminent neurologist and chairman of the Manipal Institute of Neurosciences, Delhi. With an impressive career spanning both medical services and clinical expertise, Dr. Narayanan brings with him not only a wealth of knowledge in neurology, but also a passion for advancing stroke care and enhancing patient outcomes. So, with this very brief introduction of Sir, now I would request him to please start with the topic for today. Over to you, Sir.
Good evening, everyone, and thank ISCGP for welcoming me. The topic given to me is posterior circulation stroke. I bring greetings from Manipal's hospitals in Dwarka. Challenging in the realm of cerebrovascular diseases. Anterior circulation stroke is much better understood. So that is why this topic was possibly chosen to throw some more light into the vascular supply of the posterior circulation is from the vertebro-basilar artery, which supply brainstem, cerebral, occipital lobes, and parts of the temporal lobe, which constitute the posterior circulation. The interconnections of the posterior and anterior circulations through the circle of the wrist contribute to the brain's robust blood supply. We all know about the circle of Willis here. Significant variability in the branching pattern and the absence of certain arteries can influence the presentation and outcome of posterior circulation stroke. You must remember that there is much more variation in the blood supply of the posterior circulation than the anterior circulation. Coming on to the etiology and risk factors, it is pretty much the same for both the anterior and the posterior circulation. It is either vascular disease, which is the most common, cardioembolism, thromboembolism or vessel-to-vessel embolism, hemodynamic compromise, hematological disorders, cervical artery dissection, substance abuse, and genetic factors constitute a minority of cases. 1/3 are caused by occlusive disease within the large neck and intracranial arteries. The dissection of the extracranial and intracranial vertebral arteries is another frequent cause. Unlike the anterior circulation, dissection is a more frequent cause of stroke in the posterior circulation. The common sites of atherosclerosis is represented in this graphic. It is either in the vertebral artery or in the basilar artery. Unlike the vertebral and basilar arteries, atherosclerosis and dissection of the posterior cerebral arteries is not common. Most infarcts in the posterior cerebral artery territory are due to embolism from the heart, aorta, or the vertebral arteries. What about the clinical presentation? Unlike anterior circulation stroke, which manifests with typical focal neurological deficits, posterior circulation stroke can present with a broad range of symptoms. The varied and often subtle clinical presentation of posterior circulation stroke can lead to diagnostic challenges. Distinguishing between benign causes of symptoms such as vestibular disorders and posterior circulation stroke can be particularly difficult in the acute setting. So this is a very important thing to understand. Several common disorders, for example, positional vertigo, can also masquerade as posterior circulation stroke. Unlike the anterior circulation stroke, which presents with very typical symptoms like hemisensory loss, aphasia, or hemiparesis. Some of the characteristic clinical signs of posterior circulation stroke are internuclear ophthalmoplegia, skew deviation, vertical nystagmus, upgaze and downgaze paresis, cross syndromes, and bilateral long tract signs. So unlike the anterior circulation where one part of the body is involved, one side of the body is involved, here it could be bilateral. And more importantly, cross syndromes are very, very prototypical of posterior circulation stroke, wherein the brainstem nuclei of one side are affected and the long tracts are affected on the contralateral side. The presence of multi-level lesions is peculiar to strokes in the posterior circulation. And this is explained by the presence of two or more concomitant lesions in the vertebrobasilar system that stretches along multiple structures of the posterior fossa. Vessel usually has embolus or clot affecting a large vessel. Here it can affect multiple small vessels and cause unique signs and symptoms. What about the clinical features in more detail? If it involves a lower brainstem and cerebellum, there could be true vertigo or conjugate horizontal or rotatory nystagmus. If it involves the upper brainstem and the cerebellum, there could be gait ataxia due to involvement of the superior cerebellar peduncle. Another characteristic feature of posterior circulation stroke is decreased level of consciousness and amnestic syndromes. Hemispheric symptoms such as aphasia, hemi-neglect, or conjugate eye deviations are rare, but may occur due to involvement of the thalamus, which is also in part supplied by the posterior circulation. Unilateral posterior cerebral artery stroke can mimic anterior circulation stroke. Cerebellar stroke can also lead to cognitive dysfunction due to dyschisis. Dysarthria and homonymous visual field defects are not more frequent in posterior circulation than in anterior circulation stroke. However, PCA strokes more often cause isolated field deficits than MCA hereditary strokes. Lacunar strokes are also more frequent in the posterior circulation. Small posterior circulation strokes may be more expressive than the anterior circulation, which is less densely packed with neuronal and axonal structure. So that involvement of a very small part of the posterior circulation due to lacunar stroke can present with devastating clinical features. So as we said, the circulation is from the subclavian artery, which branches to the vertebral arteries, which combine to form the basilar artery, which branch out to form the posterior cerebral artery. This by far is the whole gamut of posterior circulation strokes. Subclavian artery stenosis is most often asymptomatic, but it can cause arm ischemia and TIA. Strokes are uncommon. So if it is the very proximal part of the posterior circulation at the origin of the vertebral arteries, they usually present with arm symptoms and not strokes. Thereafter, after branching into the vertebral artery, which constitute an essential part of the vertebrobasilar system, supplying almost 30% of the entire cerebral flow, the involvement usually causes the Wallenberg syndrome. All of us have heard about it. I will not go into the details of each stroke syndrome because that will not, time does not permit me to do that. But of course, it is a very interesting syndrome, very characteristic syndrome, and very easily identifiable is one looking out for it. The clinical picture can sometimes be complicated with the appearance of central alveolar hypoventilation, which is also called the Ondine's curse or the Ondine syndrome. The anterior spinal artery, which arises from the vertebral arteries, can cause a median medullary syndrome, which is also called the Dejerine syndrome. Occlusions of the distal basilar artery are more often cardioembolic in nature. It may present with sudden decreased level of consciousness due to bilateral involvement of the reticular formation or the thalamus. Other features may be behavioral change and quadriplegia, ataxia, oculomotor involvement with either vertical or horizontal gaze palsy, impairment of the oculocephalic reflex, pupillary abnormalities, visual deficits, and sensory dysfunction. As we've seen, it presents with a whole gamut of symptoms, but I think the most important thing to remember, it can present with clouded consciousness, and this is very common in the setting of some cardiac interventions. For example, a person who's had a stenting. If in the late evening you get a call that the person has been stented with a cardiologist in the morning, with less conscious than before, one should immediately think of a distal basilar artery embolism causing this decreased level of consciousness. The artery of Percheron is a variant of the posterior cerebral artery, wherein a solitary arterial trunk that supplies both the paramedian thalami and the rostral midbrain bilaterally. So it arises from one side but supplies structures bilaterally. Ischemic strokes affecting this artery account for 4 to 18% of all thalamic strokes. The triad of involvement of the artery of Pesheron are altered mental status, memory impairment, and a vertical gaze palsy. This is a very important thing to remember, that a single arterial supply can cause bilateral stroke. So as we see, the arterial Pesheron is like from one side of the brain, but it affects and causes bilateral stroke, basically involving the thalami and the upper part of the midbrain. So how do we diagnose posterior circulation strokes? It's important to remember that the NIHSS, that's the NIH stroke scale, does not capture all the stroke-related impairments in posterior circulation stroke. It is pretty much sensitive for anterior circulation, but some of the symptoms pertaining to the posterior circulation are not well captured by the NIHSS. There is one clinical test called HINTS. As I said, vertigo is a very common symptoms of both peripheral and central causes of involvement. That is, this HINTS is used to differentiate between a posterior circulation stroke and more benign causes like positional vertigo. Again, I will not go into the details, but HINTS is an acronym for head impulse, nystagmus, and a test for skew. And in itself, it is one of the most important tests which can differentiate between the two conditions. Non-contrast scan should always be done, and it allows a reliable exclusion of hemorrhagic stroke. However, unlike the anterior circulation, it has a very low sensitivity in posterior circulation stroke, mainly due to smaller lesions and skull base related beam hardening. So the CT scan, a plain CT scan, is not as good for diagnosis of posterior circulation strokes as in the anterior circulation. There is a thing called aspects that all of us must have heard of. It is very good to see the severity of the stroke, and it is very commonly used for treatment planning in anterior circulation stroke. Similar posterior circulation aspects also been evolved, wherein involvement at the multiple levels, at the thalamus, the midbrain level, and the pontine level, each involvement at each of these levels is scored, and more the territory's involvement, the less is the posterior circulation aspect score. And obviously, if the involvement is more severe, the outcome is also poorer. The second diagnostic modality is an MRI with diffusion weighted. It is a gold standard for imaging posterior circulation strokes. And MR with DWI in posterior circulation may be negative on initial imaging 8%. This you must know. I have seen n number of cases where the first MRI is normal, mainly because I was at a tertiary care center and we do the imaging very fast. And so if there is a strong clinical suspicion, one must repeat the scan after a reasonable interval of 12 to 24 hours. So repeating DWI imaging is important if clinical suspicion is strong. Perfusion weighted imaging increases the sensitivity further. Vascular imaging is also important, and it should be performed in the hyperacute phase using a CT angiogram or a MR angiogram. To detect vertebral artery stenosis, MRA demonstrated higher sensitivity and specificity than CTA and carotid Doppler. This is important because we very routinely use CTA in the vascular imaging of the anterior circulation. While doing a CT and MRI, one should not forget to evaluate the patient in totality. So we must do a complete blood count, fasting blood glucose, lipid, coagulation studies. We must do a 2D echo to rule out a source of cardiogenic embolism. We must do a thrombophilia testing in appropriate settings to rule out hematologic cause for the stroke, an ECG which can show atrial fibrillation, genetic testing in some cases where the suspicion is strong. Compared to anterior circulation stroke, posterior circulation strokes are often recognized in the acute phase, and so they receive less reperfusion therapy and have longer treatment delays. This has been shown in multiple studies, so one should be very well aware. So one should not waste time in recognizing the presence of a stroke so that appropriate therapy can be given. IV thrombolysis can be underrepresented in stroke trials. So this is a very important aspect. However, long-term outcomes of IVT seem to be at least as favorable in posterior as in anterior circulation stroke. And most importantly, the risk of spontaneous ICH after thrombolysis is only 50% of that in anterior circulation. So there should be no confusion in our mind that all patients with suspected posterior circulation stroke who come within the window period should be given IV TPA or tenecteplase. The reason for the low frequency of ICH in PCIS after thrombolysis may be because of the smaller lesion volume in infratentorial strokes and better collateral circulation in comparison with the middle cerebral artery strokes. And because of this, some authors have even suggested that IV thrombolysis can benefit these patients even beyond the traditional window of 4.5 hours, but this is not yet part of standard guidelines. So as I said, and to emphasize, all eligible patients with acute ischemic strokes in the posterior circulation should be treated with IV thrombolysis. IV thrombolysis does not preclude subsequent endovascular therapy, although the benefit of bridging remains unproven in the posterior circulation. We all know that patients in the anterior circulation can be given thrombolysis followed by mechanical thrombectomy. So this bridging therapy is less well studied and less well known to be effective in the posterior circulation. IV tenecteplase is as good as alteplase. What about endovascular thrombectomy? The recent SELECT-2 and ANGEL aspect trials now confirm that mechanical thrombectomy compared with medical management alone improves the outcome for select patients with large ischemic strokes. So we must know that even if the stroke volume is high, they benefit from endovascular thrombectomy. So EVT is the standard treatment for anterior circulation, large vessel occlusions, but similar evidence for posterior circulation stroke has been lacking until recently. But however, several studies subsequently have shown that endovascular thrombectomy is also equally good for basilar artery occlusion. The basilar artery, of course, happens to be the largest vessel in the posterior circulation. So several studies have been published recently. There has been the ATTENTION trial, the BioCare trials, which have been presented in the European Stroke Conference in 2022. I will not go into the details of these trials. It may be out of the ambit of the current topic. But we do know that endovascular therapy does benefit patients with basilar artery occlusions. So a couple of these trials were done in China. So some authors have suggested that the study should not be extrapolated to populations with different demographics across the world. So these are the 4 trials which have shown that mechanical thrombectomy is good. Some are studied within the time window of 8 hours, but some studies have extended the window period, like the BioCare trial, to up to 24 hours. And all these trials have shown that there is benefit. What about posterior cerebral artery occlusion? Unlike the basilar artery occlusion, the evidence is less strong, though some studies have studied the use of mechanical thrombectomy in posterior cerebral artery strokes as well. However, there are no randomized controlled trials. Large observational studies have shown no difference in early neurological improvement or functional outcome. So it should not be routinely used. It should be only used as part of research protocols. So these are all for EVT in posterior circulation stroke. What about decompressive craniotomy, which again we use very commonly in malignant or large strokes with poor outcomes in the anterior circulation? In the posterior, and there are randomized controlled trials to support our practice. In the posterior circulation, there are no randomized controlled trials. However, expert opinion suggests that considering suboccipital decompression in selected patients who deteriorate neurologically from impending brainstem compression can benefit. So removal of infarcted cerebellar tissue during this procedure is controversial, may be considered in some situation. Ventriculostomy should be considered in selected patients in whom obstructive hydrocephalus is the main cause of neurological deterioration. So decompressive hemicraniectomy has a role, but it is not as clear-cut as in the anterior circulation. What about cerebellar hemorrhage? We all know that cerebellar hemorrhages greater than 3 centimeters in diameter will benefit from surgical decompression. In contrast to this, if the hemorrhage is smaller, we should adopt a careful wait and watch approach. What about anticoagulation? So there was an earlier school of thought that anticoagulation can benefit posterior circulation strokes rather than anterior circulation strokes. But however, it has now been shown that treatment with anticoagulants reduces the risk of recurrent stroke, DVT and PTE, but increases the bleeding risk. So data does not support the routine use of any currently available anticoagulant in acute ischemic stroke involving the posterior circulation. So one should not be under any kind of doubt in this. So we can use thrombolysis, we can use mechanical thrombectomy for basilar artery strokes, we can decompress the posterior circulation strokes if in some certain cases. If it is cerebellar bleed more than 3 centimeters, we can operate, but please do not anticoagulate. But if you do not anticoagulate these patients in the acute phase, but some of these patients may be having comorbid conditions which require anticoagulation. So when do we restart these anticoagulants? This graphic is very, very elegant. So we can start off in patients with atrial fibrillation if the stroke is small within 7 days, and if it is very large and there is parenchymal hematoma, then we can wait for up to 6 weeks. Similarly, timelines are given for certain conditions in which anticoagulation is mandatory, but we must wait for some time after the posterior circulation stroke before resumption of anticoagulation. So these conditions are atrial fibrillation, a cardiac thrombus, a mechanical heart valve, venous thromboembolism, antiphospholipid syndrome, if the stroke is cancer related, or there's an intraluminal thrombus or cervical dissection. The timelines for each of these is slightly different, but it generally ranges from 7 days to 6 weeks. So even in patients who have bled, we must resume anticoagulation after 6 weeks at the maximum. So resumption of anticoagulants in either acute ischemic stroke or ICH is a decision that should be individualized on a case-to-case basis, considering the severity of hemorrhage or the infarct, the risk of bleeding, and the risk of thromboembolism while off anticoagulation. Delayed anticoagulation does not prevent hemorrhage, and early anticoagulation does not fully prevent stroke. So we must decide on the correct balance, and it requires some clinical judgment and of course the weight of evidence of several trials which are available to us. Having said all this, secondary prevention is also equally important. So medical treatment and risk factor management is similar for both anterior and posterior circulation stroke. Basically, we need to give lifestyle modification and antiplatelets. They can give dual antiplatelets within the first 3 weeks, and after that we can continue with single antiplatelets. Unlike carotid artery stenting, basilar artery stenting is less studied, and it should not be done routinely. What about the prognosis? The clinical outcome after posterior circulation stroke is critically related to the involvement of thalamic and brainstem structures. So it basically depends on which part of the posterior circulation is involved. They're usually regarded as less troublesome than anterior circulation stroke, primarily due to the lower incidence of motor deficits, less mass effect, and lower mortality. So again, because some of these strokes are not very big, the prognosis is better. However, patients with thalamic strokes may be troubled by long-term sensory, cognitive, and neuropsychiatric sequelae. So it is called the Rossi syndrome, and it can be thalamic pain, as a post-stroke thalamic pain can be very troublesome. Similarly, in patients with superficial PCA strokes, visual field defects and neuropsychological deficits may remain disabling consequences. So in conclusion, ongoing clinical trials, advances in neuroimaging and interventional technologies are crucial for improving outcomes in posterior circulation stroke. And I've left some time to ask questions that the audience may have. Thank you.
Thank you, sir. Thank you so much for this very knowledgeable presentation. Sir, now, with your permission, can we take the questions from the audiences?
Yeah.
Sir, the first question is, it's from Dr. Azaruddin. The question is, could you share some specific risk factors and management strategies that clinicians should focus for better preventive outcomes, as the posterior circulation stroke have unique risk factor profiles compared to the anterior circulation strokes? So,
I'm not very sure if this statement is true. The risk factors for stroke are pretty much common between the anterior circulation and the posterior circulation, wherein I've told you there could be some vascular risk factors, and atherosclerosis involving the vessels of the posterior circulation is one of the commonest causes. Cardioembolism will come in second. As I said, cervical artery dissection is of course unique to the posterior circulation. That is one thing which is different. Hematologic factors and genetic factors and all other things, and also the risk factor profile which predisposes one to a stroke either in the anterior circulation or the posterior circulation is just about the same. But as I said, the symptomatology is different. So whereas in the anterior circulation one could have a hemiparesis or a speech defect or hemi-neglect, which are more often easier to identify, person with a posterior circulation stroke can present with obtunded sensorium, they can have visual defects, they can have vertigo, and they can have symptoms involving multiple levels of the posterior circulation. So it is very important to recognize these symptoms and identify both on the basis of a clinical profile and on the basis of certain tests, like I said, a CT scan or an MRI or MR angiogram, that the person has a stroke, and initiate appropriate therapy immediately. And initiation of appropriate therapy, as I said, one of the most important things if they come in the window period with thrombolysis, definitely will improve the outcome. And as I said, there is no difference in the improvement in outcome after thrombolysis between either a posterior circulation stroke or anterior circulation stroke. In fact, the risk of hemorrhage is less in the posterior circulation than in the anterior circulation. So I also told you that mechanical thrombectomy should be done in the right time frame in basilar artery occlusions. Decompressive hemicranectomy can be considered in some patients. So the management protocols are similar, but there are some unique differences as well.
right, sir. Thank you so much, sir. Moving on to the next question. Since imaging plays a crucial role in stroke diagnosis and management, What are the recent advances in imaging or technology have proven most valuable in identifying posterior circulation stroke, and how have this impacted the treatment protocols?
Like I said, the CT scan, which is of course the first test that we do in all patients with stroke to differentiate ischemic stroke, acute ischemic stroke from hemorrhagic stroke, is less sensitive for picking up because the lesions are smaller and there are artifacts due to the presence of the skull base. So because of that, the CT scan is very insensitive for picking up posterior circulation stroke. So we must immediately, in patients where we suspect a stroke, do an MRI, and diffusion weighted MRI remains the gold standard. But we must supplement this with perfusion imaging that improves the sensitivity. And then we must do an MR angiogram. A CT angiogram is less than in the anterior circulation. There are so many other imaging advances, basically on MRI protocols and all that, which are out of the ambit of routine clinical practice. But if you remember, a CT scan followed by a diffusion weighted MRI, followed by a perfusion imaging, followed by a MR angiogram, this pretty much gives us all the information to treat patients with posterior circulation stroke effectively.
Right, sir. Sir, there are two more questions. With your permission, can I take them up?
Sure, sure, any number.
Yes, sir. The question is, posterior circulation stroke often present with non-specific symptoms that can complicate the diagnosis. So what are the key clinical indicators or diagnostic strategies that you would recommend for early detection?
So I did mention some, but of course it's very difficult to mention all of them. One of the commonest presentations is vertigo. And there is we must differentiate central vertigo, that is because of a posterior circulation stroke, from peripheral causes like a positional vertigo. And for that, I told you the hinge test, that is the head impulse, nystagmus, and test for skew deviation. That is a these three parameters, if we do, it pretty much differentiates between this and the peripheral cause from a central cause. But of course, we must not waste too much time doing all these tests while we proceed to do an imaging. The second one is there are some peculiar features like a crossed hemiparesis, where there is involvement of the brainstem nucleus on one side and involvement of the long tract signs on the other side. So this is a very typical features. Involvement of multiple cranial nerves. So this is another peculiar feature of posterior circulation stroke. These are all clinical parameters. Obtundation of sensorium is much more common. It's very common if there's a bleed in the anterior circulation. But here, even if it's ischemic stroke, obtundation of sensorium is very common, particularly if the thalami are involved. If both the thalami or the upper part of the midbrain, the reticular activating system is involved. As I said, one of the common causes of this is an embolus arising during a cardiac intervention procedure. So the person, one must understand the clinical setting, one must have a high index of suspicion, but having said all that, one must quickly proceed to do the appropriate investigation, the most important being the neuroimaging.
Right, sir. Thank you so much for answering this query. There is one last question. So, given the potential for significant disability post-stroke, what are your recommendations for long-term rehabilitation and follow-up, specifically tailored for patients who have suffered a posterior circulation stroke?
Yeah, here it depends on what the deficit is. Like some patients, like I told you, thalamic pain is very, very common after posterior circulation stroke. So when the person has got thalamic pain, they must be counseled. We use medications like duloxetine and pregabalin, which are pretty effective. But if they do not respond to this, we must take the course of consultation with the pain management specialist. Suppose they have vertigo, and which is troublesome, then we must do some specific therapies which are tailored for vertigo management. If they have involvement of gait and balance because of, let's say, cerebellar stroke, so balance training becomes important. If they have long tract signs which are much more common, that like hemiparesis, which can also happen. In fact, these patients can be quadriparetic as well, because they can have involvement of the long tract laterally. So if they have spasticity or weakness involving the limbs, so the treatment must be tailored for that. They receive spasticity treatment, physical therapy, vocational therapy. So all these things are equally important in the posterior circulation as in the anterior circulation. So rehab is a very important component. I'm happy that this question came up. We always tend to discuss the management of acute ischemic stroke and leave the rehabilitation part towards the end or not discuss it at all. I'm happy that this question came up. It's a very important component of stroke management.
Right, sir. Thank you for answering this question, and thank you to the one who have raised this question. So, sir, with that, we come to an end of this session. And, sir, I would like to thank you immensely for taking up your time, for providing your guidance, and for guiding us through this very complex topic. And thank you so much, sir, for putting your effort for making the presentation, then answering all the queries so patiently. So thank you so much, sir. Thank you so much from the IGCP group and from
Thank
all
you
our
so much.
viewers.
It's always a pleasure to be a part of the meetings. Thank you so much.
Thank you so much, sir. Thanks to all the viewers for joining in for their participation. Thank you all. We are closing the session for now.